My name is Steve Mora. I'm an orthopedic surgeon. I specialize in sports medicine. I'm in Orange County, Southern California. Any other orthopedic surgeons out there? Can I see a show of hands? Okay, since you're orthopedic surgeons, I'm guessing that you probably like to bench press, right? That's what we like to do, right? Can I see a show of hands who does like to bench press? Okay, great. I used to like to bench press as well until I started doing this procedure. Chronic pectoralis major tendon tear reconstruction utilizing amniotic anti-adhesive membrane and Achilles allograft. That's the title of my talk. I have no disclosures to state. What's the problem? The problem is these folks, they've been living their life with a chronic tear for one reason or another, and I'll explain why in a few minutes. They've been living their life with a concavity of their chest wall, an asymmetry. Oftentimes they will have this band of tissue that connects the torn pectoralis major to the biceps. It's actually very painful. It's sensitive, it's painful, it's very thin. A lot of subcutaneous tissue around it. And of course, loss of the lateral chest wall border and a very atrophic looking chest wall to the point that these folks don't want to take their shirts off. I mean, that's actually the main reason why they come to me is because of the cosmetic appearance of their chest wall. You know, there is a solution. I would call it a partial solution. It's a reattachment of the pectoralis major back to the proximal humerus, and that's done with allograft tissue. Achilles allograft is one of a few tissues that's used to mechanically pull the tendon back up, reattach it to the proximal humerus. Something that we've been doing in other types of procedures. But when it becomes chronic, it's a little bit of a different ballgame. You have a bigger dissection, bigger surgical exposure, a lot of adhesions that you have to release, more post-surgical bleeding. The incision sometimes is bigger, and there's more potential problems with post-surgical adhesions, puckering, et cetera. So remember, these folks have a problem with the way their chest looks. So the goal is to make sure that you do a good job so the chest looks better. So surgical repair does not always lead to satisfactory results. That's what some of the literature shows when we're dealing with chronic tears, okay? So this is how they typically occur. You know, we have this gentleman that's bench pressing, and that's about when it happens, right when the barbell is almost hitting the chest, every time, pretty much every time. And it's the lower fibers, the lower sternal head of the pectoralis major. That's the one that rips because of the suboptimal position. So, we'll move on in a minute if you have a hard time seeing this. But the reason why, I'll move on. Okay. But that's what happens, you know. So, so those of you that raise your hand, that you bench press, I have to tell you that it can happen anytime. It can happen even while warming up. It's the sternal fibers are at maximum tension right when you're at 30 degrees. So right before that barbell hits your chest, boom, that's when it always happens. So why do they become chronic? You know, why do they become chronic? They're usually misdiagnosed or underdiagnosed. Okay, misdiagnosed or underdiagnosed. And number two, the patient is basically told, you don't need surgery, you're going to be fine. And they will be fine in terms of function, but they're not fine in terms of how it looks. I mean, they're fine for regular activities of daily living, but they're not fine for what some of these people want to do in life. So misdiagnosed. Why are they misdiagnosed? Because people will order a shoulder MRI. The shoulder MRI does not go low enough, so you can't quite see the tendon. Or they show up late in presentation because they thought it was just a sprain. They went to an urgent care. They told them that they had a strain, especially when they show up with this bruising of the upper arm, 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 and bruising of the upper arm in this one. So they show up with bruising of the upper arm, and what happens, somebody orders a plain MRI of the shoulder, it gets missed, they eventually realize they have a deformity. So misdiagnosed, underdiagnosed, tears are not obvious on exam. So for example, this gentleman came to see me 2 weeks ago. If you look closely, you'll see the signs of bilateral pec tears. Okay, number one, on this side right here, you see that band of tissue that I mentioned. It's a fascial band that attaches the torn pec to the biceps almost every time, and it's tender. It doesn't belong there. And then on this side over here, the nipple line is a little bit lower, and they lost the lateral chest wall border. Okay, this patient was misdiagnosed with was told he had biceps tears. So So patients are told surgery is not warranted because oftentimes patients are told you have a muscle tear and we don't fix muscle, or they show up late and they're told that it's too retracted, can't be fixed. This is just a quote from one of my patients who sent this to me. I fixed this gentleman's tear about 12 weeks ago, but this is what he told me. He tore it when he was 19, okay? This tear was over 10 years old. I tore it originally in the fall of 2009 when I was 19, was told by many doctors surgery was off the table and no longer an option because he presented late, meaning like after 6 weeks, it's a harder surgery. And then I do a lot of work online, and when a patient actually sent this in, or a gentleman sent this in talking about his experience, his tear was 13 years ago, and somebody convinced him that it would be fine, and it wasn't. You know, they're not fine. You know, one thing that I failed to mention actually when I was showing you that video that I showed you with the pec tear that I moved through really quick, that video was an online video on social media. That video got millions and millions and millions of hits online. Okay, millions. You know, and so when I was in training, I saw one. The first 5 years, 10 years of my practice, I saw a couple. You know, now that I'm 20 years into my practice, I see one a month, literally, or more. Or more. So why is it? And I mentioned this on a past slide. I think it's social media. This is actually my opinion on this. There's a lot of people that are showing their abilities on social media, especially trainers. And when you're on social media and you're a trainer, you're showing off your stuff. You know, you're showing off what you're able to do. And a lot of people make fun of people that want to get likes. Well, those likes equal a lot of money, tons of money for these folks, you know? So, you know, you go on YouTube and you get a couple million likes, you just made a couple $1,000 or more, actually. So, so that's why they show these videos online. You can find thousands of these videos online of people getting pec repairs, okay? So, by the way, I'm online. Please make sure you like my information on Instagram, all right? Okay. Okay. So how do we make these patients better? Well, they're just normal people that want to look better. You know, they have half their chest wall missing. You know, it's like having a Cyclops lesion. It doesn't feel right. It doesn't look right. So what can we do as surgeons? We can improve their function and with the right approach, improve their aesthetics. Allograft tissue connects the torn fibrosed tendon, reestablishes the length, which allows the muscle to work. And number two, amniotic tissue is able to reestablish the health of the connective tissue, the adipose tissue, the fascia, the tissue planes. Now, why am I interested in this and how do I know about this? Because of my personal experience, actually. That knee, that beautiful knee right there, that's actually my knee. I was involved in a motor vehicle accident, open fractures of the distal femurs. And you know, it was left to heal on its own. Unfortunately, even though I was under 5 years old, what Dr. Kaplan said didn't quite happen. I didn't get a perfect looking skin. I ended up with a very ugly keloided scar that's attached to my IT band, and the IT band is actually adhered to my lateral femoral condyle. So I'm thinking about the future as an orthopedic surgeon. What's going to happen to me when I need knee replacement because I have post-traumatic arthritis? It's relatively severe. So I'm thinking about the future. I'm thinking about my surgeon sticking these Z retractors in there and spreading the wound. And based on how it looks, I'm expecting, you know, Z retractor to just go right through that scar. So I'm planning ahead. And this is how I got into this amniotic membrane. That's my wound, my scar. That's me doing my own surgery. Just kidding. Right. So okay, so see, I'm sliding this tissue underneath the amniotic membrane. I'm sliding it underneath this release scar, and there it is afterwards. The lighting wasn't that great, but much more mobile, much nicer feeling tissue. So, you know, I started to think about this and how we can apply it to PEC major patients. And one of the reasons was that, you know, I did do some of these a few years ago, and I did notice puckering. There's puckering right where, at the point where the attachment site is done, especially when you use an allograft. And I figured, you know, I wonder if we can put something there that is slippery and slimy so that the skin doesn't attach to it. So I thought about amniotic membrane. And as a reminder, this amniotic membrane, it enwraps the fetus in the placenta, separates the fetus from maternal cells, basically. protects it physically and also from a immune response from the mom. So that's what this amniotic membrane does, especially the membrane that's nearest the fetus. Now, the membrane that's actually around the umbilical cord, that amniotic membrane is thicker, so it's easier to use, and that's what I use. I use the umbilical portion of the amniotic membrane. It's been used in other applications in orthopedics, especially ocular medicine. It's been used for tendon reconstructions, ocular surgery, and trauma to help regenerate tissue or promote normal tissue growth. Okay? There's a number of commercially available products online. Some of them are processed different than others. Some of them are thicker than others, et cetera. These are some of the ones that are available. All right, let's get to the nitty-gritty, the fun part, the surgery, right? At least for me. So this is what I do to improve the outcome of the surgery, not just for function, but also for the cosmetic result. I use the incision in the axillary fold, so anterior axillary incision rather than delta pectoral. Delta pectoral leaves an ugly-looking scar right in the front, and it adheres to the muscle underneath because there's not a lot of tissue there, a lot of subcutaneous tissue. So that's number one. Number two is preoperative markings. This is one of my patients just before surgery. I look at the patient, I look at his chest wall, and I kind of look at the V shape of the chest, and I determine like where that attachment's going to be made so that I can have a nice, symmetric, aesthetic look after surgery. This patient is post-op, by the way, right there. You can see that. Pre-op markings, where the attachment will be made, where the stump is at. I can usually feel it. Let me tell you, it's hard to see. It's easy to feel pre-op, but once you get some swelling in there and you get your hand in there, you get blood in there, it's actually hard to feel that stump again. So I kind of have an idea where it's going to be. And then there's the Achilles allograft. This is what I call my back table art. I like to draw, so just showing where the attachment is going to be. This Achilles is already prepared for placement. This is a video that basically goes through the surgery. That's one of my drawings that I made for a patient. And then this is actually a drawing that I made. I do a lot of virtual consults or educational sessions, so I like the patient to know what I'm going to do as I'm looking at their MRI, and this is the usual situation. Sternal head is torn, retracted, fibrosed, clavicular head is usually fine. I first attach the Achilles graft to the humerus. That's something I do a little bit different, but there's different ways to do this. So Achilles allograft, I feel the shape is kind of natural. I'll pull up the fibrous muscle, pull it up, attach it with tension onto the Achilles, and lay the graft down. So you're going to see that in just a second here if it turns on. There we go. Okay, anterior axillary incision. There will be a little blood here in case anybody's squeamish. Okay? Not a lot. Mobilizing the muscle, very careful to stay on top of the muscle and not underneath because the neurovascular bundle is underneath the muscle. You don't want to go under the coracoid either. Tag it with very thick, high tensile strength sutures. If you're a fisherman, it's about 300-pound test line. It's a very strong line. And tag it, kind of figure out where it is that I'm going to reattach it. That's my little mark on there that I had before surgery, that for my preoperative planning. That's going to be the plan. You know, the standard drilling of for the endo buttons, 2.4 guide pin followed by 4.5 millimeter cannulated drill. There's my Achilles allograft. I trim it, I tag it, I place the buttons through it so that I could use it in a pulley technique. And then that's a video showing pretty much what's going to happen here in a few minutes. Pull it into the joint. I pull it into the joint using, or not the joint, sorry, the proximal humerus. See, I'm really careful not to retract that deltoid too hard. Everything is done gingerly so as not to damage the soft tissues. Slide it in. That's a big wad of sutures, and that's my concern. Because of the big wad of sutures there, then I know that there's going to be some scarring there. So that's where I plan to put this amniotic membrane right on top of it. Amniotic membrane is ideal because I can actually sew it in. It's thick, workable, it doesn't fall apart. And that's from the umbilical cord, the umbilical portion. My goal here is to create a nice tissue plane. I really want to create a nice tissue plane so that the muscle can glide and not adhere to the subcutaneous fat or the fascia of the fat. This is one of the patients that's post-op. About 2 months post-op, looks really good. Just wanted to share this with you. I don't really have a lot of data right now. I'm collecting data on these patients because to my knowledge, it's the first time that I've seen this repair being done with amniotic tissue for the purpose of improving the cosmetic outcome as well as the soft tissue envelope. So I don't have the data right now, but I'm going to leave you with this. Okay, this is a patient that tore his pectoralis major 10 years ago, over 10 years ago. He put a tattoo on, or he had a tattoo placed, thinking it would hide his problem. It didn't really hide it. You can still see the concavity, loss of lateral chest wall. You can tell the difference here of the border of the chest wall if you reference the tattoo, so you can see where it's at. It's more symmetric. This is what he said. I've always been subconscious about the way my pec looked prior to surgery. For years, I wouldn't take my shirt off on the beach since I knew I had an atrophy on the right side. Not anymore. My chest looks symmetric. My pec looks normal. Not only the tear has been repaired and reconstructed, my self-esteem has been as well. See, these guys, they're really affected by this emotionally. Like I said, it's like having a cyclops eye in your forehead and walking around with it. It's not something that anybody wants. And the other issue is, they do bench press. They love how they look. They want to stay symmetric. They want to stay aesthetic. This is terrible for them. Takeaway and conclusions: reconstruction of the chronic pectoralis major tear can lead to good cosmetic and functional results, and the unique properties of amniotic membrane fit well into the goals of treating these folks, especially with the goal of having a great aesthetic result. Thank you so much.